Good morning. So my name is Ben Campbell. As Dr. Quiros said, I'm one of the 30 residents at UCLA. I'll be talking about IgG4-related ophthalmic disease. I have no disclosure, but I want to acknowledge Dr. Quiros and thank him for this case. So we'll start off. So our case is a 46-year-old Hispanic male who presented to the emergency room with a progressive visual loss over 1 week. He also noted headaches for the past 8 months. They were more severe over the last few weeks, pressure-like, intermittent, starting occipitally and radiating to the front with initially relieved with ibuprofen, but not so anymore. A CT head was done in the ER, which was negative, and ophthalmology was consulted to further evaluate. On review of systems, he denied any pain with eye movements, denied any fevers, chills, weight loss, shortness of breath, chest pain, nausea, vomiting, diarrhea, joint pain, dysuria, or hematuria. He did report fatigue, loss of concentration, progressive hearing loss for months, scrotal pain, and a rash on his leg. As far as history, pertinent past medical history, positive for diabetes, hypertension, dyslipidemia, rheumatoid arthritis that was diagnosed 8 years ago but had since been quiescent. He took medications for these problems, except for the rheumatoid arthritis. He's a carpenter by trade, 30-pack year tobacco history, occasional alcohol use, no drug use, and unremarkable family history. On exam, you can see his best corrected visual acuity was hand motion on the right and no light perception on the left. His pupils were reactive but very sluggish, with the trace APD in the left. Intraocular pressure was normal. Slit lamp exam was largely unremarkable, except for some mild to moderate background non-proliferative diabetic retinopathy. So an MRI was done. You can see here on this T1 image, axial through the orbits, that it's largely unremarkable, except when we add contrast, we can see this diffuse dural enhancement and thickening of the meninges, left greater than right. And if we go to the coronal cut, we can again appreciate the thickening. And also through the optic nerves, we note bilateral enhancement of the intraconal optic nerve sheath. Several labs were performed on this patient. This is a busy slide, but basically most everything was negative except for A1C was positive, ESR and CRP were elevated, ANA was mildly elevated, but otherwise a fairly unremarkable laboratory workup thus far. A lumbar puncture was performed with opening pressure of 32, 21 white blood cells with 80% lymphocytes. Glucose was 90, which is elevated, but likely normal for our patient who has poorly controlled diabetes. Proteins normal, cytology negative, 1 oligoclonal band, and infectious workup was negative. But his IgG levels were elevated. Serum IgG concentration was 2,000. And in the CSF, the IgG synthesis rate was elevated, along with the total IgG and the index IgG, which compares the CSF to the serum in relation to the albumin level, as you can see there. A dural biopsy was performed, and we can see here in figure 1 at medium power, there's thickening and fibrosis of the dura, as well as the lymphoplasmacytic infiltrate. Then at higher power, we note a perivascular and interstitial distribution of the lymphoplasmacytic infiltrate. And stains for IgG were positive and IgG4 with a ratio of IgG to IgG4 greater than 40%. Our patient was diagnosed with IgG4-related disease involving bilateral optic nerves and meninges, and he was started on IV steroids for 9 days. He had significant improvement in his vision to 20/20 on the right and 20/30 on the left, and was subsequently discharged home on oral prednisone. But he had a relapse and was readmitted 4 weeks later for worsening vision and headaches. At this time, his vision was 20/60 on the right and count fingers on the left, and he was treated with IV steroids and plasmapheresis. He initially had some improvement and was discharged home on oral prednisone, but this time added on Rituximab due to his recurrence of disease. But he really had no improvement and poor response to the Rituximab, so that was discontinued and azathioprine was started along with a steroid taper. So I'd like to talk a little about IgG4-related disease. It was first recognized in 2001 in sclerosing pancreatitis, and then in 2003 as a systemic condition. It's characterized by fibroinflammatory lesions described in virtually every organ system, most commonly involving the pancreas, liver, kidney, lung, orbit, salivary glands, thyroid, lymph nodes, and meninges. It's idiopathic in the sense that we don't know its cause and detailed pathogenesis, but the clinical pathologic criteria for its diagnosis seem sufficiently separate and specific to separate from other forms of idiopathic orbital inflammation. And the role of IgG4 that we'll talk about it actually remains unclear, but it's used as a diagnostic marker. There's likely a spectrum of this disease, and previously classified disorders such as McCulloch's disease, multifocal fibrosclerosis, sclerosing cholangitis, and others likely fall along this spectrum and are related. So as I mentioned, the diagnosis is a clinical pathologic one. IgG4 serves as a biomarker, and immunostaining is an essential test. This is where it gets tricky because there's no formal guidelines for diagnosis. There are a few classification parameters that have been set forth, but they vary a little bit in what's recommended. The main thing is the proposed criteria have different requirements for the quantitation of IgG4 cells. They agree that it must be numerous, but how many cells are necessary? It ranges from 10 to 200 cells per high power field. And the ratio that we talked about with our patient that was elevated of IgG4 to IgG plasma cells can be useful, but it's not specific, as the criteria of over 40% of this ratio can be seen in other diseases such as rheumatoid arthritis. So one of the first classification or diagnostic schemes that was presented from Japan from Umehara and colleagues had three major criteria. One, clinical examination showing characteristic diffuse and localized swelling or masses in single or multiple organs, and then an elevated serum IgG4 concentration, and histopathology showing marked lymphocyte and plasma cell infiltration of fibrosis, and then infiltration of IgG4 plasma cells with that elevated ratio we talked about, and greater than 10 IgG4 cells per high power field. So it's a definite diagnosis if you had all three, probable if you had 1 and 3, and then possible with 1 and 2. Then later that year, an expert panel gathered and provided a consensus statement for the pathologic criteria. They had, again, three major criteria. One, a dense lymphoplasmacytic infiltrate. 2, fibrosis with at least focally storiform. And then 3, with obliterative phlebitis. And these are two images here of a typical, on the top image you can see the lymphoplasmacytic infiltrate with typical storiform fibrosis, the bottom with obliterative phlebitis. Usually 2 of the 3 major criteria are required to make a diagnosis, but there are many exceptions depending on the actual tissue involved, the lacrimal gland being one of them. They also had some minor criteria that were often associated with IgG4-related disease, one being phlebitis without obliteration of lumen, and the other increased number of eosinophils. This is a table from their consensus statement, going through and highlighting some of the differences for diagnostic criteria based on what tissue is involved. So you can see I've outlined for the lacrimal gland, the fibrosis actually doesn't have to be storiform, it often isn't, and it often lacks obliterative phlebitis. So with the lacrimal gland, you often only get the lymphoplasmacytic infiltration. Then further, they went on to quantify how many cells per high power field should be involved based on the tissue. You can see the lacrimal gland is over 100, whereas for the meninges it's just over 10. So there's great variation as I discussed earlier in how to classify this. So let's talk about just the ophthalmic disease. It is one of the more common manifestations of IgG4-related disease, affecting approximately a quarter of patients based on some studies. Its most typical presentation is a chronic, progressive, painless periorbital lacrimal gland or lid swelling, which can be unilateral or bilateral. And from a review paper, looking at a couple studies that try to classify which presentations are most common, we can see that most often it's bilateral, most commonly involving the lacrimal gland, but also can involve the trigeminal nerve, extraocular muscles, orbital fat, eyelids, and nasolacrimal ducts. The symptom duration, as in our patient, can be long, months to years, And vision loss can occur secondary optic neuropathies in our patient. And then it also can affect other tissues in the head and neck frequently, such as the salivary glands and meninges. More diagnostic criteria has been put forth to further classify the ophthalmic version, to specify the diagnostic criteria just for the ophthalmic version of disease. This is another group from Japan in 2015. It's similar to the first diagnostic criteria I showed, but more specific for the eye. Imaging studies must show that there's involvement of structures of the orbit. The histopathologic examination has many of the same features, but they do note that it must be 50 cells per high power field, and blood tests with the elevated serum IgG4. And with definite if they have all three, probable if they just have one or two, and possible with one of three. So this is kind of a classic presentation for of the most common presentation of this disease. This is a patient who initially presented with bilateral lacrimal gland enlargement and salivary gland enlargement, as you can see in the top figures there. And the bottom four figures actually are years later, when this patient then presented with extraocular muscle involvement years later. Let's talk about treatment. Corticosteroids, as in our patient, initially are very effective, but unfortunately relapses are common, and it's often unsustained the response. So other immunosuppressive agents have been tried, including methotrexate and mycophenolate. Radiotherapy has been tried, but with variable success, and Rituximab actually has been reported to be fairly successful. Unfortunately, it's not so in our patient. And the mechanism by which all these work, is especially Rituximab is unknown, but it's postulated that the B cell depletion and modulation of the dysregulated T cells play a significant role. And then these patients should be referred to rheumatologists for systemic workup, as half of them with ocular disease will have systemic involvement, according to one report. So in conclusion, IgG4-related disease can affect essentially any organ in the body. The ophthalmic disease is likely responsible for a significant proportion of orbital inflammatory disease that was previously diagnosed as idiopathic. And it should be included in our differential diagnosis of any lymphoplasmacytic or sclerotic orbital lesion. The pathophysiology and role of IgG4 cells remains unclear. And the diagnosis and treatment is limited in the sense that we don't have there's a lack of shared classification criteria or formal diagnostic guidelines. And there's no evidence-based therapeutic recommendations so far. And as such, further research is needed to study this disease and further investigate therapeutic interventions. Thank you.
Thank you, Dr. Campbell. Those are very complete literature. I really appreciate that. Do we have any comments or questions for Dr. Campbell? Dr. Rubin?
Thanks. That was a great presentation, because it really represented IgG4 disease quite well with that final slide, which was a whole bunch of non-specific, confusing, and poorly understood conclusions. And that pretty much summarizes IgG4-related disease. You've heard me talk about this before. Often when I talk about IgG4 disease, it reminds me of this television commercial from the 80s where there's, it's like for Sanka, or coffee beans. There's a whole bunch of beans on the table, and then a guy takes a stick and he slams it down on the table and he wipes off 80% of the beans, and he says, "These are the best beans. These are the ones. Now this is Sanka coffee." And it's kind of like that with IgG4-related disease. You have this spectrum of tissue response, and you kind of like slap the stick down and say, at 40%, now we have a specific disease condition. But that's not really the way that biology works. The reason why there's so much challenge in trying to define the definition of the disease and the treatment is that it's most likely a common end pathway of multiple inflammatory processes. And so you have various diseases that are very poorly understood that used to be in this grab bag category of NSOIS, and now we've kind of like parsed them out by their tissue response. But the other thing that you don't talk about very much is the other side of it, which is all of the other diseases that we previously thought to be specific. For instance, GWP or xanthogranuloma and all these things, that they also have IgG4-related responses. So it's really hard to see what to make of it. I mean, there's not a defined kind of clear definition of what the clinical syndrome is for sure. It can happen in all sorts of places. It can be, you know, in different parts of the body. It can be one part of the body. There's also not a specific definition of what the pathologic response is. In the lacrimal gland, you don't need storiform fibrosis and obliterative phlebitis, but in other places you do. There's also a lack of you know, treatment paradigms. So sometimes really responsive to steroids, sometimes not. You know, and it makes you question, like, what exactly are we pulling together here? What is this? There is no, you can't quite put your finger on it. So maybe further research is needed. Probably, you know, that's always the conclusion. Many times you don't understand something, further research is needed. But what, you know, what does it really mean for us now? I would say in practical terms, the real use of IgG4 is that these diseases we used to understand as having, you know, relatively severe and progressive kind of clinical syndrome, but we often had trouble convincing rheumatologists to step up their therapy. They would give them some low dose or medium dose steroids, and they wouldn't kind of go to the next level. But now we say, oh, well, it's IgG4-related disease, and now they'll give them, you know, Rituximab, or they'll give other biologics, which can help these patients. So I think it's useful in that way, but I don't really know how to kind of like, you know, capture it and call it a distinct entity. We, you know, when I present the review of orbital disease, which you know, the residents know well, it's a subcategory of NSOIS for me. I don't really know what it means. I don't know if there's other experiences I am out there with the plastics community, but I just have trouble holding on to it.
In this particular case, the neurologic syndrome, the meningeal syndrome, I should say, is actually pretty well characterized, and they do tend to respond very well to Rituximab if you get them early enough. That's the problem, right? Because there's the meningeal disease does have a very pronounced obliterative phlebitis. So obviously, if your optic nerve sheaths are enhancing because they're meninges, and that's the blood supply to your optic nerve, and you have obliterative phlebitis there, well, you're not going to get very much improvement once all those blood vessels are gone, right? Once you've destroyed that pia arachnoid. But if you get it early enough and prevent enough of that, then you pretty much will prevent that posterior ischemic optic neuropathy, which is what we see in these patients. And so we do know that these patients do tend to respond very well to Rituximab. And again, it's an excuse to give them Rituximab, so to speak, right? Because the insurers won't pay for Rituximab. There'll be weeks of delays in terms of getting these patients treated, even in rheumatology clinic, because they can't get authorization for the Rituximab. But once you sort of put out the diagnosis of IgG4 disease, you can get them Rituximab the next day. So at least it serves that purpose for now. But I agree with you, it's still it's a grab bag category. But at least the meningeal disease seems to be very well characterized in that it has a very high incidence of obliterative phlebitis. Dr. Quiros.
Ben, that's a wonderful presentation and a great review in the commentary. There are a couple of clinical pearls to share. And that is, sometimes when we do a biopsy and the pathologist says orbital inflammatory disease, we really need to push the pathologist to better characterize it and look for IgG4 as well as other inflammatory indicators. And sometimes the orbital presentation is the only presentation. And we have to remember that these patients need to be sent for systemic evaluation. The other problem with IgG4 disease in the orbit is that no matter what the treatment, very often the disease is chronic and sometimes progressive. So for this particular inflammatory disease, whereas in many others we will say do a small biopsy, if you have an opportunity, I think it's helpful to the patient if in a non-destructive manner, especially if the disease is extraconal, to surgically remove as much of the disease you can. And that'll be better for the long haul. Thank you.
Thank you, Dr. Quiros. Any additional questions or comments for Dr. Campbell? Thank you, Dr. Campbell.